This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today for another episode of the Rational Wellness Podcast. For those of you who enjoy listening to this podcast, please go to iTunes and give us a ratings and review. That way more people can find the Rational Wellness Podcast. Also, there's a video version on YouTube. And if you want the show notes and a complete transcript, just go to my website, drweitz.com. Our topic for today is small intestinal bacterial overgrowth, which is the main cause of irritable bowel syndrome in approximately 70% of the cases. Today, we plan to focus on how best to understand some of the mechanisms, the latest diagnostic methods, and to hopefully gain some new insights on which integrative treatment strategies work and don't work, and how best to take a deep dive into SIBO, then with our special guest, Dr. Allison Siebecker, the queen of SIBO. I feel so fortunate that I recently had the opportunity to speak to Dr. Pimentel, the king of SIBO, and now I get a chance to speak to you. Dr. Allison Siebecker is a naturopathic doctor and acupuncturist, and she's very passionate about education. She specializes in the treatment of small intestinal bacterial overgrowth, and she teaches advanced gastroenterology at the National University of Natural Medicine. She also lectures all around the world at conferences, and she has the most incredible resource of research articles and information about SIBO on her website, siboinfo.com. Allison, thank you so much for joining me today.
Thanks, Ben. So happy to be here.
So how did you get interested in digestive disorders and SIBO in particular?
Like so many people, it's because I have the problem. So I think as far as I've known, I could recall I had what I now know to be IBS since I was about 5. So it was interesting because I wasn't born with it. My parents and family tell me I had normal function, like normal bowel movements and things like that. But after somewhere around 5 or 6, I became constipated and also had bloating. And I never knew what it was. No one in my family knew what it was. And, I spent this whole time trying to figure it out. I mean, it's not really why I went to medical school, but it certainly is what steered me in this direction, And so I read various things, and then I came upon the term SIBO, and it all clicked. But there was barely any information out there at the time. It's just like 14 years ago or something like that. And so, or maybe, I can't remember exactly how long ago. So then I just started researching, and then that's when I made my website, because when you would Google or search, nothing would come up. There's one Medscape article, and there was where you could get the test came up on like page 4. And it was like, so then I made my website. Now, of course, my website's like, is it even needed? Because, everyone and their brother and their cousin has a site on SIBO, but it's done its job. It helped people during the pinch when there was no info.
No, it's still a great resource, especially the way you update all the, most recent studies.
Yeah, I'm so glad that you use that, because I work really hard on that. And it's very interesting to me. Every quarter I go through, and anything new that's been published on SIBO, I put on my site. And especially my favorite part is the associated diseases page. And there's just studies, like you just wouldn't believe the studies, things you'd never even think of, like acromegaly, being associated with SIBO, and a study on it. It's like, wow, okay.
Yeah, skin disorders, epilepsy. I had a woman who had seizures. She lost her driver's license. And you fix the SIBO and she's better.
Wow.
It's great. to start off with, I want to take a little bit of a side turn for a second. In the 70% of patients that have IBS, which is caused by SIBO, I wonder what about the rest of the other 30% or so? What do you think is probably the cause of their IBS? Or is it SIBO that we haven't been able to diagnose because we don't have the new breath test, the hydrogen sulfide, or what? Do you ever speculate about the other 30%?
That's such a good point that you bring up. So the other 30% is the differential diagnosis, right? So which, just for any layperson listening, that just means what else could it be, right? So, and this is what we have to go through in our heads. The differential diagnosis for IBS, irritable bowel syndrome, is huge. And that's because the symptoms are what is called nonspecific. So, the symptoms are bloating, constipation or diarrhea, or a mixture of the two, and abdominal discomfort or pain at the minimum, right? So what causes that? Like so many things, right?
Right.
So, right now I just brought up in front of me on my screen, just to remind myself, the list that I compiled of the differential, and it's got 40 conditions on it. And
wow.
So I'll just read a few of them. And,
sure.
and some of them could be causes of SIBO, but some of them, they might not be causing SIBO. They just have similar symptoms. So we've got things like yeast overgrowth, parasitic infection, large intestine, overgrowth or infection, H. pylori infection, celiac disease, non-celiac gluten intolerance, inflammatory bowel disease, IBD, carbohydrate malabsorption, like lactose or fructose. I mean, people can have that, not have SIBO, and it causes the exact same symptoms. Food intolerance, which most people typically think of as a protein type allergy, but there's also histamine intolerance, salicylate, on and on. General hypochlorhydria, too little stomach acid, that can be caused by 15 to 20 things, so just irregardless of SIBO. Pancreatic enzyme insufficiency, diabetes, hypo or hyperthyroid. These have the same symptoms. Something as innocuous as, this does need to go on the differential for IBS, insufficient chewing, right? So I have all these dietitian friends that tell me that's the first thing they do when someone has IBS symptoms, is they coach them on how to chew their food well and be able to do that, because, instead of you just have the impulse to swallow real quick, and that a large proportion of their patients, the IBS, so to speak, is solved by proper chewing, right? Then all the way on the other side of this differential diagnosis, we have got cancer. Any kind of cancer of the abdomen could create the same symptoms. So we've got from the innocuous to the very serious, there's things like gastroparesis, low stomach emptying, bile acid malabsorption, VIPoma, Zollinger-Ellison syndrome, any kind of obstruction in the small intestine, Parkinson's, scleroderma, systemic sclerosis, Ehlers-Danlos syndrome, mast cell activation, MCAS, mast cell activation syndrome, POTS. These are sort of the new kids on the block. Everyone's like, whoa, complicated patients might have these. These
right.
have the same symptoms. Lyme and co-infections, various immune deficiency diseases actually have the same symptoms. And endometriosis, that's a really common one. A lot of patients with SIBO will have that as their cause, like endometriosis. But even if you don't get SIBO from endometriosis, it has extremely similar symptoms: swelling, bloating, pain, diarrhea. You can even vomit from the pain, So there you go. That's not the complete list, but right. It's a massive differential.
Right. And of course, these can be coexistent with SIBO at the same time. You can have several layers of problem dysfunction.
Most patients that I see have more than one thing wrong. Right? Same with you. Like, have you ever seen anyone with just one thing wrong?
Sometimes, yeah.
Woo! So, we have to keep that in mind.
Right.
Because patients a lot of times are like, what's the one thing? And
right.
It's often more than one.
Yeah, I try to get all the patients with gut disorders, at the very least, to get a stool test and a breath test, so we can at least start to put a couple of layers together.
Excellent. Yeah, so the thing about this is that what I think happens to a lot of people with IBS, unfortunately, is it's not investigated at all. Like this differential I was just reading, which SIBO would be on, which is with the 60 to 70%, prevalence, and then all these would have 30 to 40% prevalence. No one looks at any of them. or maybe they look at one thing. Maybe the doc is advanced enough to check for SIBO. But if that was negative, then they don't look at all these other things. So, you just have IBS. So I guess the thing is, what really is IBS? In my mind, the way I think about it is that it's what would be left if absolutely every single one of these 40 plus things is ruled out, which of course then that's a burden on everyone, the system and tests, and it might not be practical to rule out all these things, but I'm just saying philosophically, what is it? It's still just a name for when you've looked at everything and you don't know what is causing these symptoms, right? Right.
And then of course, if you do find several different things, it's a question of what do you prioritize? If there's SIBO and there's blastocystis hominis, or there's candida, or there's dysbiotic bacteria, or there's worms, what do you treat first? Do you treat both things simultaneously?
Questions. Just big old questions there.
But, that's something that would be interesting, that kind of have some guidelines as a continuum as to, okay, if it's a parasite, treat that first, then SIBO, if it's,
Yes.
But, that's part of the art and science of practice.
Yes. Yeah.
So, when I was speaking to you at the Integrative SIBO conference in Seattle, you said that you thought that we generally think that the bacteria in the small intestine have overgrown from the large intestine. That's especially the story that Dr. Pimentel tells, because of a decreased motility, and then you get this backwash. And you said to me that you think that's not what happens in a lot of cases, that the bacteria come down from above. Is that right?
Yeah, I don't know. It's just that I've read so many articles on SIBO, obviously. I've got like 2 file cabinets full. I've read them all multiple times. And it's just that there's something hasn't made sense to me. And I get a picture in my head. And what seems likely to me is that all 3 things are possible in terms of top down, bottom up, or just from the small intestine itself. So I do think it's possible we can have a back migration, but I think it's just as likely, if not even more likely, that the normal bacteria that are in the small intestine are simply not moved down and are overgrowing. And also, we have bacteria entering into us constantly every day at like all times, swallowing, eating, everything. They're in the atmosphere, they're everywhere. Those, basically think about it. How did our large intestine get colonized with these bacteria? Some say from vaginal birth. What if you weren't vaginally born? They're going to come from somehow the top down, and they're going to be passing through us. So what if then those bacteria just didn't get the chance to move all the way down? What most experts say is that the way you say it's SIBO is that the types of bacteria that are in the large intestine are now in the small intestine. That is a very strongly held opinion, but it is debated. It is debated. There are articles currently, in fact, just our symposium, our integrative conference in New Orleans, which was a year ago, we had 2 researchers discussing sort of the oral upper respiratory bacteria, that being a form of SIBO as well. So even though it's what is generally held, I just want people to know that there are other people thinking other thoughts and publishing on that as well. And I did talk to Dr. Pimentel about this and ran some of my suspicions or thoughts by him. And he did say that the bacteria that are down in the large intestine do also exist there in the small intestine in a very small amount. And they could just be overgrowing right there. So that's an odd thing, because they're really large intestine bacteria, but then if they're always there in the small intestine in small amounts, are they just large intestine bacteria? So now he's just come out, Digestive Disease Week is just occurring right now, the big conference, gastrointestinal conference. And he's just come out with a full sequencing of the small intestine microbiota. He's been working on new technology, and I've quickly looked at those articles, but they were abstracts. So I don't have the full information. Maybe this will become a little bit more clear now.
Yes. I had the opportunity to interview him, and he was telling me about that he's mapping the small intestinal microbiome. So I've really been enjoying this discussion, but I'd like to pause for a minute to tell you about our sponsor for this podcast. I'm proud that this episode of the Rational Wellness Podcast is sponsored by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help our patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative. This is a great resource for education for practitioners. I'm a subscriber to TAP Integrative. There's videos, there's lots of great information constantly being updated and improved upon by Dr. Lee Salschuler, who runs it. One of the things I really enjoy about TAP Integrative is that it includes a service that provides you with full copies of journal articles, and it's included in the yearly annual fee. And if you use the discount code Weitz, WEITZ, you'll be able to subscribe for only $99 for the year. And now, back to our discussion. There's a number of factors that have been discussed in the literature that help to keep the small intestine relatively free of bacteria. As most of our listeners probably know, your colon is packed with tons and tons of bacteria, and there's bacteria throughout our digestive tract and in most of the mucosal surfaces of our body. But the small intestine is supposed to be relatively free of bacteria because that's where most of the absorption of nutrients occurs. And so getting too many bacteria becomes problematic. And there's a number of mechanisms by which the body typically keeps the small intestine from having too much bacteria. And those include hydrochloric acid secretion, digestive enzymes, bile, motility, the migrating motor complex, the ileocecal valve, which, if it maintains its integrity, prevents the bacteria from the large intestine from growing in. And then 80% of our immune system is focused around the gut. And so, that's referred to as the gall. And that also helps to keep the small intestine clear of bacteria. And I asked Dr. Pimentel about this, and he's a big believer motility is pretty much the main factor. He doesn't think that the others are really important factors. And I also spoke to Dr. Rabar recently, and he thinks that a lot, especially the problematic cases of SIBO, we're really dealing with dysfunction of the immune system, and that's one of the underlying problems. What do you think? Do you think these factors can all play roles, and which do you think are the most important?
Yeah. Okay. So I think certainly what everyone else thinks and what the literature supports is motility and the anatomy or the structure of the body. So the migrating motor complex probably being number one, and number two being the anatomy of the intestines allowing for the passage of bacteria down. So like the number one problem that would happen there would be obstruction, some kind of partial obstruction. If those things fail, we know it's really high likelihood someone will get SIBO. So that's very well accepted. But then when we look at all these other factors, there's not a lot of studies to support, or there's a lot of contradicting evidence. I also agree with Dr. Rabar that I think the immune system would be number three, coming after structural and motility, as a very important factor. How important, I'm not sure. I actually brought up a chart. I want to give you the rates I have in one of my slides. The rates of immunodeficiency that have been, of SIBO in immunodeficiency that have been published. Okay. We don't have a ton of articles on this, right. But we've got anywhere from about 18%, that's for common variable immunodeficiency disease, up to 88% for HIV, which is that's pretty extraordinary, right? And if a person was to go and look at this article that was written on SIBO and HIV, one thing you would need to keep in mind is that the positive value for, they used culture, they used culture test for the the diagnosis, the positive value for that has changed. And so this article says that it's not very associated because it was using the old standard, which was 10 to the 5th or 10 to the 6th, and now it's been lowered to 10 to the 3. So taking into account the 10 to the 3, it's 88%. So, and then we've got chronic lymphocytic leukemia, 50%. That's really high. And various immunodeficiency diseases in children, 41%. The thing about this is that these are all frank immunodeficiency diseases. So I think what a lot of people wonder about is, what about when you see, like on a test, like you see low IgA on a saliva test or a stool test? What about that? And we just don't know. I think what we can say is, yeah, I think it would be a risk. You know, I think it would. How much, we don't know. At least when we have these frank immunodeficiency diseases in our mind, these percents, we can maybe put it into perspective. But like, for instance, with Lyme, we know that Lyme is an underlying cause for SIBO. And there's various theories as to why, and one of them is the nerve damage that occurs, probably from one of the co-infections. But the other is the immune system deficiency that occurs, and I think it's an important factor. So I would put that as number 3 after first motility, and then structural, and particularly obstruction, partial obstruction. Now, bile, enzymes, hydrochloric acid, these are not much is known about the bile and the enzymes. Hydrochloric acid, that one's hotly debated. Really where it's debated is with proton pump inhibitors. So deficiency of hydrochloric acid, it's actually really well documented in studies that it leads to an overgrowth of bacteria in the stomach itself, right? That's, you know, where that acid is missing. So for me, the concept with how it would then lead to SIBO is then that overgrowth would just move on over, spill over into the small intestine. If the migrating motor complex would be working, it could clear it out. And we actually have studies that simulate this, where tubes have been put right into the upper small intestine with fecal bacteria, like, you know, like an FMT type of situation. Okay. And then, but those people have been shown to have a functioning migrating motor complex, and all the bacteria was cleared out and they didn't get SIBO. So that's the concept I think we're working with here, is that therefore how much would hypochlorhydria affect? I think it would be a significant risk factor if someone also had deficient motility. And, you know, I could imagine in a scenario like this, you have some deficiency of motility, maybe not enough to give you SIBO, but you're heading in the direction, you're like, oh, you're at risk. Then you have the low hydrochloric acid. Together, it gives you SIBO. See, that's what I would imagine, right? So now with the proton pump inhibiting drugs being such a highly popular prescribed drug, they on purpose create hydrochloric acid deficiency. And that is hotly debated, back and forth. For every article that comes out saying that they're a risk factor for SIBO, another one comes out saying that it's not. Just now, Dr. Pimentel's team came out at DDW with one saying it's not. So I feel like this is going to go on forever. To me, if you've got half the article saying it's a risk factor and half saying it's not, I don't know. To me, I feel there's a risk factor there. I believe it's a risk factor. Right. That, you know, it puts you at greater chance. That's all. I don't think it's a major underlying cause.
I spoke to Dr. Reze, who's one of Dr. Pimentel's associates, who spoke at one of our functional medicine meetings, and he discounted it as a possible factor because he said that once the hydrochloric acid gets into the proximal part of the small intestine, it gets flooded with bicarbonate, so would have no effect in the small intestine anyway. In other words, it gets neutralized.
I remember you told me that, and I thought that was so interesting because I think he was thinking of a different mechanism here for how it would cause a problem. For me, I'm thinking of actual spillover, you know.
Yeah, I was thinking that it had a, you know, antibacterial effect.
Yeah, right. I wasn't thinking of it in that way. I had a different concept. But let me just think if there's anything else. Oh, the ileocecal valve. Now that one's also very controversial because you brought that up, right?
I did, yes.
Yeah, okay. Because I actually have, it might be interesting if I bring this up. Let me just see here. There have been a lot of studies, well, not a lot, but like some, that really show it's not so obvious that it is for sure a problem. And again, I think what we're looking at here is the migrating motor complex having the ability to compensate. So we actually have some studies like that where people have their ileocecal valve removed, but they have intact migrating motor complex, and they don't get SIBO.
So these people had part of their intestine removed due to cancer or IBD, right?
Exactly. Yeah, let me see if I can bring up the one. There was one that they had controls. Let me just see here. I want to see if I can find it. Okay, I'll just read you what I have because it's kind of interesting, right? So in a study of 17 children with bowel surgery, they found that the loss of the ileocecal valve was not associated with an increased risk of bacterial overgrowth. And another study looked at 40 patients with SIBO and concluded there was no significant difference between patients with and without SIBO and the presence of the ileocecal valve. And then there was this one that was, let me find it, 8 resection patients. It was removed. The ileocecal valve was removed because of cancer. And this was the one. They had 8 controls. And they found when the distal small intestine, ileocecal valve, and proximal large intestine were removed, but the transit was normal. The small intestine transit was normal, the same as the healthy controls. There was no reflux from the large intestine into the small intestine, the remaining aspects. Now, they didn't look at SIBO. They looked at reflux, but they did not see it back migrating. And the motility was normal. So, and there's more. There's studies on children and everything. This is not to say it isn't a risk factor. I believe it's a risk factor, but I guess the concept is to get across here is that risk isn't a guarantee, right? It's that it increases chances somewhat. So here are people that have their whole ileocecal valve removed and they didn't get SIBO, right? So, but then other people do. You know, I have patients who they have an absent ileocecal valve and they have continuous chronic SIBO. It's interesting. What they did find actually in the study with one of the children's studies was it had to do with the length of the small intestine that was removed. And the more small intestine that was left in the body, the lower the chance of SIBO. And again, they didn't say it, but my thought here is because then it could perform the migrating motor complex. It has the chance to do a clearing downward sweeping action. So, you know, I would say for anyone who's needing to have their ileocecal valve removed, there's a couple things to ask for, and that's to leave as much of small intestine as possible. And also there's studies done where they reconstruct and create a fake valve. That actually also helps. So, and then there's studies on which fake valve works better than the others.
Oh, okay.
So you can, you know, if somebody is listening and heading towards that in surgery, they can look into this.
Interesting. So which are the most effective antimicrobial herbs for SIBO, hydrogen, methane, hydrogen sulfide, et cetera?
Well, there's a whole bunch that we use that seem to have equal effectiveness. So we use berberine-containing herbs. So you can buy products that just say berberine or berberine complex, things like that. But the herbs that have it are golden seal, Oregon grape, things like that. So that's an excellent one.
Does it matter if the product is from all those variety of different berberine containing herbs, or has the, you know, complete herb, or just a berberine extract? Do you think those are equally effective?
I do. I've tried single herbs and I find them to be just as effective as a combination. The only difference for me with a combination is some people are quite sensitive. A lot of people with SIBO are very sensitive to really anything that comes in. And so sometimes it's nice to use just one item and not multiple herbs, because then if they become reactive, you just have one thing to remove and figure it out. You know? But so that's excellent. One thing I want to mention about that is that the dose for berberine, I have found, at least in my patient population, which is a bit more of the challenging, we need a pretty high amount. So I use, and my colleagues use 5 grams a day.
Oh, 5 grams.
In split dose, yeah.
5,000 milligrams. Okay.
That's it. So it winds up being anywhere from 9 to 11 pills. Now, a lot of my colleagues say 3 grams, 3,000 milligrams is plenty. But I guess the key thing I want to get across is 2 pills a day, 3 pills a day isn't going to do it, right? So. And
is that the same if you're using it with 1 or 2 other herbs?
It is.
Okay.
It is. Okay, then the next one would be neem, N-E-M, and the one we tend to use a lot is called Neem Plus by Ayush. It has a tripholate in it, which is maybe a mild prokinetic. Again, we're adding extra things here, but people tolerate it very well. And we use 6 pills of that one a day. And then oregano, I tend to use one that's not an oil in a capsule because I find the oil in the capsule is a bit more caustic. Sometimes oregano is hard on people's mucous membranes and it can hurt. Other people do fabulous with it, no problem. But the one that's in a dry tablet seems to be tolerated by more people. And of that one, I use the one.
Which product is that?
I use Biotics ADP,
okay,
or oregano, and we use 6 a day again of that. And then there's Allison, the antibacterial aspect of garlic. The product we use is called Ali Med. It's also sold as Ali Max Pro, but that Allison company, they have 3 levels. They have Ali Max, which is the lowest, Ali Ultra is middle, and Ali Med is the highest. And so we use the highest one, and that we use 6 a day of that. Now that one is the one, the Allison, is specific for methane. So the other 3 work beautifully on hydrogen, and actually the AliMed works well on hydrogen, but we don't typically start with that because it's more so for methane. So for myself, I will use 2 herbs at once. So I would do berberine neem or berberine oregano or oregano neem, and that for hydrogen. And then when someone has methane, I will choose one of those 3, and I will add AliMed. Another one we can use for methane is atrantil. And so I can use that one alone sometimes, or I'll just use it like the AliMed. Those are our main workhorses, and I find them all to have equal effectiveness. But I do just want to say another point here is a lot of docs, particularly those who are more primary care physicians, they'll use combination formulas that also have herbs that work on yeast and parasites and viruses, big antimicrobial formulas. And I talk to them and they report good effectiveness with that. I just don't go that way because I'm not seeing that population. I'm seeing people that have already failed, and I'm getting a bit more specific. But either method works well.
What about the elemental diet? Have you found that to be effective either by itself or in combination?
Well, we don't use it in combination. I mean, I guess there are some people that do, but that's against Dr. Pimentel's recommendation. He's the doc who came up with this as a treatment for SIBO. It's highly effective, highly, highly effective. So I feel in terms of like killing, I guess it has equal effectiveness to herbals or pharmaceutical antibiotics, but it has this one advantage, which is that it can kill more in the same time period. So we'll typically see somewhere around 70 to 100 parts per million of gas be lowered in 1-2 week course, like a huge amount. So it's a special treatment because it can save time. Because a key thing to know, it's sort of like the little gold piece that I figured out very soon into my SIBO specialty practice, is that both herbs and pharmaceutical antibiotics seem to lower gas on average around 30-ish parts per million per treatment course. A treatment course for pharmaceutical antibiotics is 2 weeks. A treatment course for herbal antibiotics is 4 weeks. It takes longer with herbs to get the same effect. So within those time periods, we tend to get around a 30 part per million decrease. It's all they can seem to do. I mean, occasionally, of course, you get something fabulous, and you're thrilled. But elemental diet, on average, lowers about 70 in 2 weeks. So it's not a very pleasant treatment. A lot of people don't want to do it, but you really have to think about this, because if you've got high gas, that could be what would convince you, let me just do that elemental diet,
And do you prefer the dextrose or the dextrose-free version?
I like to use dextrose. And now this is not for a patient that has yeast, obviously, or a strong history of yeast. It's going to be problematic. But the only reason why is because I have a lot of sensitive patients, and I've had a lot of patients who reacted poorly to maltodextrin. So most formulas either have maltodextrin or maltodextrin with dextrose, which is glucose. So I think those are all wonderful, but if you're just truly asking if I was going to pick one out of everything, I would probably pick a dextrose simply because I've had a lot of patients react.
Right. Do you find some patients are developing antimicrobial resistance the way patients can develop bacterial resistance?
I remember you sent me this question ahead. This is to herbs, right?
Yeah, to herbs. Yeah.
Yeah.
So like they can't tolerate oregano anymore, or they don't react to it the way they used to.
I find this in just about every patient I see. It is absolute norm. Now, this could be, of course, because I'm seeing people farther down their journey and they're harder cases. So everyone I see is going to have this kind of thing. It is expected and the norm. I see it all the time. So I constantly have to rotate my herbs. And this is another reason why I don't like to use big, huge formulas, because then I'm exposing them to everything. I want to pick and choose, and I want to reserve herbs aside for future use, because most people need multiple rounds because of this high gas and
And is it around 4 weeks, 6 weeks, 8 weeks?
So yeah, as I mentioned, for pharmaceuticals, it's 2 weeks. Elemental diet, it's 2 weeks. Herbal antibiotics, it's 4 weeks. Of course, we can stretch that out a bit. So we can go to 3 weeks for elemental diet, which isn't the most pleasant, and pharmaceutical antibiotics, and 6 weeks for herbals. And the question here is, well, why not just keep going and get the thing done? And it's because I find that it peters out. And I've seen this over and over and over. And particularly for like herbal antibiotics, I will see patients actually start to relapse while they're taking the herbal antibiotics, usually in around 6 to 8 weeks. So I don't usually go past about 6 weeks. I know a lot of docs standardly will just give an 8-week. In my patient population, I can't do that because they actually begin relapsing. So I certainly have seen some cases where people have been on like 3 months of pharmaceutical antibiotics and it was still like working and lowering, but that is not the norm. That is like a rare circumstance. You just seem to like not get any more effect. A point of diminishing returns after about 3 weeks for pharmaceuticals and 6-ish to 8 on herbals.
What are the most effective natural pro-motility agents?
Well, for the natural prokinetics, by the way, a funny thing here is, a lot of the SIBO patients have diarrhea. And so I specifically don't say pro-motility agent because they're going to go, ah!
Of course, exactly.
I can't take it, right? So prokinetic, I like to use that term instead. And I always try and tell the patients that have had diarrhea or still do that they can take it because it's not a laxative. It's possible that it might give them a worsening of diarrhea because pretty much anything you give could, right? And certainly as you're stimulating the upper small intestine motility, it might, but in general, we don't see that it does that. So for the natural ones, I don't really see one of our options being more effective than another. I see so we have ginger, which if you just use that alone, ginger root, it would be 1,000 milligrams at night before bed. And then we've got all these ginger-containing prokinetic formulas. So there's Modal Pro, there's Prokine, there's SIBO MMC, there's Motility Activator, and from the UK, there's bio.me.kinetic. Am I forgetting any? Did I get them all? I hope I did. Well, anyway, so we've got all those, and they'll usually have things like 5-HTP and a few other things that can help potentially stimulate migrating motor complex. And then we've got Iberogast, and I would say they're pretty equal. We just really have the Iberogast and then ginger or ginger-containing formulas. For the pharmaceuticals, we have the main ones we use are low dose.
Let me just ask you another question.
Oh yeah, sorry.
How easy it seems to me that with the prokinetic, the natural prokinetics, it's hard to gauge their effectiveness, and a lot of patients don't necessarily feel anything. And I often wonder, should I be going up on the dosage? And then especially maybe you have a 240-pound patient. And, what do you really think are take some of the popular ones like Motility Activator, Motil Pro, or what do you think is the most effective dosage?
Well, it's the same issue with the pharmaceutical prokinetics. No matter what, whether it's natural or pharmaceutical, how do we know it's working? This is like so frustrating.
We need a way to test motility,
Yes. So, very unfortunately, fortunately and unfortunately, there was this machine that was being developed right when I first talked to Dr. Pimentel. He was helping them run tests on it. It wasn't his development, but he was helping. And it was acoustic. and it was meant to be able to tell us about the migrating motor complex. I spoke to them, and they just decided not to use it for this purpose at all. And apparently it's not even available. Honestly, I haven't checked back, and I should. We were all waiting for this. It was like, this will be the way. We'll be able to take a baseline, then give someone a product and check them again, right? So right now, the only way we would be able to know is two ways. One, you would send them for the costly, invasive, have to travel to it, antroduodenomanometry test, which is the way you test for the migrating motor complex. And then that's performed as a functional test, at least the way Dr. Pimentel does it. So you would test a baseline, then you would give them the product, and then you would test again. Can it make their migrating motor complex? Well, obviously this is not very realistic, right? So then what's the other way we would know? We would know from watching how they relapse. How frustrating, right? So when do they relapse? I mean, the best thing I can say about this is, I would say for patients that are not doing badly, right? They probably...
What about having them eat some charcoal and see how long it takes to come out in the stool?
That's transit. That doesn't really have anything to do with migrating motor complex. Yeah. I mean, you've got several regions, very different motilities. So anyway, I would say that your relapse rates, if a person's doing pretty good, they're probably in the 4 to 6 to 8 month range of relapse, even out to a year. When a person is a chronic patient, they often will relapse at about a month or 2 months. So if you have to judge like that. If your patient is relapsing, they get better, and then they relapse at 2 months, that's pretty average. So now I got to try and do something to make this better. So then you might increase your dose. You might add a second prokinetic. All the prokinetics, and I didn't mention the pharmaceuticals, so just quickly, low-dose erythromycin, prucalopride, and LDN, low-dose naltrexone. These are the main ones we use. All of these that I've mentioned have different mechanisms of action and therefore can be used together. The one thing is you just want to be very careful with erythromycin because it can prolong QT. But with these particular prokinetics, they can go together. But just anything you're going to add with erythromycin, check it, right? But so then I will do that. So then I might combine two. So to your question, what about if somebody's heavier weight? Should you go up? You can go up. I wouldn't go higher than 2,000 milligrams in a day of ginger. That's just from reading studies. And for the low dose that we use for pharmaceuticals, I wouldn't go above the standard dose. So, but for erythromycin, see, the thing is, with that one, it's the low dose that really has the prokinetic effect. When you start going higher, it actually doesn't work as well as a prokinetic. I wouldn't go above probably 100 milligrams 2 to 3 times a day on erythromycin. For the ginger,
has anybody experimented with red yeast rice? Because I know Dr. Pimentel was talking about using low-dose statins at one time.
Yes, now that's different. What that's about is not as a prokinetic. That's about inhibiting methane gas formation. And then the idea would be your motility, because methane gas causes constipation. It slows motility. So this is a different mechanism. But people have. And, when I first did, it was a little like I had some positives, I thought, and then I had some negatives. And then when I really followed it out, I really didn't have those positives. You know how like when you do something and you're like, oh my God, it's working. And then there's confounding factors. And then as you trace it through, you're like, wait, that wasn't it,
Right.
So I actually feel better about the Atrantil for this purpose than the red yeast rice. So back to the question of like, should you increase your motility activator, you can. Just check that dose of ginger and don't go above 2,000. But yes, you absolutely can do that. One problem with those is that the ginger often burns people's throats. So that can be a limiting factor or causes reflux.
Yeah.
In many patients I've had, they just want to drink water because they like the effect of it. One last thing on this. There are patients that are sensitive enough that they can actually sense and feel a prokinetic working. And it's an odd thing to describe, but I wonder, you might have had some patients give you this feedback. It's different from when somebody has a really excellent bowel movement and they feel all cleared out and they're like, oh, wow. But yet patients will say, I feel cleared out, but it's not like a bowel movement. It's like an upper clear out. And they'll say things feel different. Things feel like they're working better in this. It's like the upper abdomen region, and they get a good feeling, Some patients, the vast majority, they can't tell a thing. Oh, and one last thing. patients will often confuse this with bowel movement, and they'll say, oh, well, I'm not having a bowel movement any more than I was before, so my prokinetic isn't working. It's not supposed to give you a bowel movement.
Right.
So.
Have you experimented with any of the manual or other techniques for stimulating the vagal nerve?
I haven't. Actually, I did experiment with gargling and gagging, like the classic from Dr. Karazian, and I found no benefit at all, which has been confounding to me because Dr. Karazian reports these amazing case successes, and I was dejected. It was like, why aren't I seeing this? Now, I did hear a lecture recently by Neil Nathan. He just came out with the book Toxic, and he was talking about polyvagal syndrome and various vagal issues, and he did make this one comment that depending upon the reason of what's wrong with the nervous system and the vagus and everything, possibly those exercises just might not be targeted enough to, there might be some more targeted treatments that would help. So that's about the extent of my experimentation. Do you want to make comment on this?
We've experimented a little bit with using infrared laser and, chiropractic treatment, sometimes to the thoracic spine or the cervical spine. I'm not really sure if it helps or not, but.
Well, if we're on the subject of what could help nerve repair, I think there's a few things that I would be aware of, and you might have some others to offer. One is prucalopride. It is a neuroregenerative. So that's the prokinetic. That's probably my favorite prokinetic that we have to offer because of this. It actually protects nerves from damage and regenerates them. And then it also stimulates the migrating motor complex. So I like that one. I think doing things that help protect from autoimmune damage, because that's a lot of people are having SIBO from autoimmune damage to nerves, like in the case of food poisoning, the most common cause of SIBO. That's the mechanism there. So anything we can do to calm down autoimmunity. So LDN that's another one of our sort of prokinetics, could help that. But then my colleague, Dr. Mona Morenstein, she uses acetyl L-carnitine. She specializes in SIBO, but also diabetes. And that's been proven to help regenerate nerves in diabetic neuropathy. So that'd be another option. And then myself and Mona also have both spoken about lion's mane mushroom has been shown to help do some nerve regeneration.
Interesting.
And then, yeah. And then lastly, frequency-specific microcurrent is something I've just recently been learning about. They have an enteric nervous system healing protocol, and also a vagal healing protocol. They can heal a lot of tissues with frequency-specific microcurrent. So that's one I'm getting very excited about.
I'm loving this conversation, but I think I only have time for one more question.
Oh, really? Only one more? Come on.
Unfortunately, the last question is going to be a big question, but
okay.
Probiotics. Do you ever use probiotics part of your treatment protocol or after the treatment protocol?
Yeah.
I know it's controversial. There's a thought that any kind of probiotics is adding bacteria and we're trying to get rid of bacterial overgrowth. It's a bad idea. There are some prominent functional medicine doctors who feel like probiotics should be frontline treatment because of the antimicrobial effects. Some functional medicine doctors say, well, I use probiotics, but I don't use those. I just use soil-based or I just use, Saccharomyces. So what are your thoughts?
Exactly. I'm Dr. Horolac, he's wonderful on showing what strains have been studied, and he's got some strains he's educated us a lot. Some bring down methane. There are other studies that show probiotics help motility, right? So, and maybe even the migrating motor complex. So it is really confusing. I am absolutely not opposed to probiotics. Most of the studies on SIBO and probiotics are positive, right? They show actually probiotics decontaminating, like decreasing the rate of SIBO due to antimicrobial aspects. I can't say I've seen that in my patients. This is a case where for me, the studies don't match clinical, although I haven't exactly tried the same strains because a lot of them in the studies are unavailable, at least in the U.S. So that's one of Dr. Hawryluk's arguments. He's always arguing for strain specificity and that you can't just generalize and say, well, I tried probiotics and, you have to try the exact thing that was in the study. So here, I guess what I could say is this. I am not of the belief of one way or the other. Like there are some docs who say no one with SIBO should have, or like there should be no probiotics used with SIBO. And others say everyone should use them. I'm in the middle because I just like to go by the case of the person in front of me and ask, because so many patients are very aggravated by probiotics. And my explanation for this, with SIBO would be cross-feeding, because when you give a probiotic, it makes acids, and then other bacteria can then take those acids and turn them into gas. And so I think that it's possible for probiotics through cross-feeding to increase gas. And it's the gas, that hydrogen, methane, or hydrogen sulfide, that causes the symptoms primarily. We have other pathophysiologies. That's the number one. So sometimes, it's just going to be too aggravating. So what I do is I just ask, how have you done with them? I take a look at the brands they've had. I always want to see if they had one with a lot of prebiotics in it. Prebiotics can very much aggravate symptoms, especially if there's a large amount. And I think also we can, on a side note here, we can use prebiotics. Certainly some are better handled than others, and especially if you start very slow and go lowly, high, bringing it high up slowly. But I guess what I would want to say about this is my preference is to try probiotics while a person still has SIBO, while you're giving antimicrobials. Because if there is a real problem, you can be simply correcting with the antimicrobials. And the other reason is because in the past, I followed the classic thing that everybody does where
the 4R.
Yeah, right. You mentioned this to me, where you give the probiotics when you're done, right? And I had a lot of problems with that. I seemed to relapse a lot of my patients, and I didn't forget it. I felt so horrible that it isn't my preference to wait and try probiotics after everything's perfect. I do not like to rock the boat because these people are sensitive. It took us a long, hard time to get their tests cleared and get them feeling, because I've challenged, we work like to get them, okay, now you're at 80%, now you're at 90%, woo, we got you, it takes all this time. I don't want to rock that boat. So I would rather rock the boat when we're in the middle of treating. And, so that would be my personal recommendation, is try probiotics when you're still treating. Of course, you can try them at any time, but I'm just sharing what happens with me.
So basically you're saying a 4R approach, which is, almost like a biblical verse in the functional medicine world, probably first taught to us by Dr. Jeffrey Bland, maybe the father of functional medicine, that basically we want to remove, replace, reinoculate, and repair. That protocol probably isn't great for SIBO.
I don't think it exactly fits, but it's not awful. Obviously we're doing the remove or the reduce.
Right, with the antimicrobials or antibiotics.
The replace, I feel a lot of people can start with the replacement right up front because it helps with symptoms anyway. So, you don't have to wait. So, but it's still good. And then does everybody need that? Also, no, not everybody needs the HCl or the bile or the enzymes. Again, you could just try and see. And then the reinoculate and repair. Reinoculate, again, I might like to give that a test a little earlier. And then repair is nice too. The interesting thing is that there was these two studies done on SIBO and leaky gut. And what they both showed, so they both actually showed about a 50% rate of leaky gut and SIBO, which is surprising. I think most people would think it would be like 100%, right? So, and I tested a bunch of my patients, and I also found a 50% rate, if we believe our tests, right?
What tests do you do for leaky gut?
I was doing the Cyrex test, Array 2. Because there's issues if you use lactulose, right? Sorry, because it's the same test used for SIBO.
Right.
So you could get a false negative. But anyway, all right. So anyway, then what these two studies showed is that they did nothing other than clear the bacteria. And then they retested 1 month after the bacteria was gone, the SIBO was negative, and close to 100%. In one study, it was 100%. Another, it was like 80% of the patients had their leaky gut. They were now healed. And so what this really shows us is if you remove the cause, if you really did identify and then remove the cause, the body heals. Unless you have some wound healing issues, it should be able to handle it. So do we have to go in there and throw in all these repair elements? On the other hand, if we get a cut and we put aloe on it, it heals faster. So, okay, it's just for discussion, right? But I do think some repair things are nice. And I just want to share one of the ones that I've been liking the most recently, because I've tried so many things with my patients, is actually the serum bovine immunoglobulins.
Oh, okay.
I used to use colostrum all the time, and I'm finding that the IgG, the purified IgG, is more effective. One thing colostrum has that purified IgG doesn't is it has epithelial growth factors. And honestly, that's what I was really after with the colostrum. But I'm more excited right now about IgG than the whole product of colostrum. So just thought I'd share that.
Okay, awesome. Unfortunately, I have a patient coming up here. Well,
fortunate for them.
So how can our listeners and viewers get a hold of you or find out about your programs?
Yeah, so just my website is SIBOinfo.com. And I would highly encourage signing up for the newsletter, because that's where I put all that. It comes quarterly, and then with event updates whenever there's classes or conferences or something. So that's where the newest news comes.
Awesome. Thank you so much, Dr. Siebecker.
Thank you, Ben.
Okay, talk to you soon.